Thank you, Narsingan sir, and thanks to the organizers of this conference and the sponsors of this session, Eli Lilly, for involving us and an important symposium on newer paradigms in the way we approach obesity and other metabolic disorders with the advent of the newer therapeutic agents. You all know that we as speakers in a sponsored meeting in part of conferences are contracted and receive honorarium for these kind of talks, explicitly expressed by me. And you take it with a bucket of salt if you want, but thankfully the talk which I am going to give is scientific, almost near 100%, because we are talking only the background in which all this started. Thankfully, the drug part of it will be discussed by others, but the background in which these drugs invention are exciting us will be discussed by me in the next 15 minutes or so. This slide is often repeated in most of these sessions. India is exploding with more and more data on increasing in the burden of diabetes and obesity. As the name of the conference indicates, it's diabesity parallelly, and today in the first session we discussed thyroid also. If you put here, it will also parallel. Anything related to obesity, if you put a graph like this, there will be an upward trend on this. As was mentioned in our Indian Journal of Endocrinology Metabolism 2012 or 13 editorial, we should become the diabetes care capital in the near future rather than the diabetes capital of the world, which is the dubious distinction, which I think China is more, even and many countries are now competing with India on this. Anyway, and we know that diabetes is not just blood glucose. It is beyond that. There are conventionally, traditionally, for teaching purpose as well as conceptualization purpose, we approach the complications of diabetes as a vascular disease with macro and microvascular complications. Thankfully, how much ever new drugs come, new things come, these things don't change. You approach it conventionally, you will not go wrong. So you should remember that diabetes by definition itself is based on microvascular complication. And even though macrovascular complication kills the patient more commonly, especially the cardiovascular events, let us not forget that in India, kind of a heterogeneous population with a spectrum of varying affordability, varying presentations, and all other complications are also as common as CV risks. And there are few things added to this now. That's what they want to mean. So as metabolic physicians, endocrine physicians, we all know that diabetes is part of a bigger metabolic syndrome. And that metabolic syndrome has a common hypothesis, soil hypothesis of obesity. That's where we will come to over the next few slides. And once obesity, weight gain sets in, and it is well demonstrated that the insulin resistance also go hand in hand with the obesity. Mechanisms are many, and once the insulin resistance and things set in, your beta cells are going to struggle harder to work. That's the way we can put it simply. And there is a cutoff point, or somewhere along the line when the beta cells are struggling and over secreting, they give way. And that absolute insulin deficiency heralds the progression of hyperglycemia. Till then, how much ever your beta cell functions very well, you will not develop diabetes. This is also well demonstrated. If you are able to compensate for insulin resistance very well, you will develop hyperinsulinemic features, but not hyperglycemia. But beyond that somewhere there is a cutoff. It will be individualized probably, but in UKPDS and all, they have clearly shown that every patient with diabetes, when you diagnose with hyperglycemia, approximately 50% of beta cell function is already low, is what has been demonstrated. And putting it in the other way, if you manage diabetes in that early phase very well, the remaining 50% at least can be saved, or the dysfunction can be improved, and that will help your overall diabetes care over the next decades better than you allow it to worsen. You go into that insulin requiring phase of diabetes. And whatever we are discussing in the last few minutes is type 2, by the way. We are not discussing the other forms of atypical or type 1 and other forms of diabetes. And these are all disturbing statistics, very often repeated. and at individual level, all of us have a big role to play. There are, suppose, 100 people here. Each of us will be seeing even 10 patients. You can touch 1,000 people's life over the next few days if you can address better care for our patients. That's what I think these conferences are meant to be. And in spite of this, statistics tells us that most often our patients either come late, or even if they come and discuss, they take a longer incubation period to accept and go for treatment, and all the other informations from non-allopathic and other non-modern therapies, conventional therapies, they also come into the play. So it's a multifactorial reasons behind why we are, first of all, treating our patients late, delay in intensification. The physician inertia part at least can be addressed or allayed by these kind of meetings is what we feel. The patient-related inertia and population-related problems, education is required, etc., has to be from a different perspective. And early treatment is associated with fewer complications. This is landmark papers, UKPDS in type 2 and DCCT in type 1. Without them, none of the last 2 decades discussion, newer drugs, nothing will be there. Before 1990s, I think sir is there, a lot of senior physicians are here. Before I did MBBS, you would have done your post-graduation or seen patients. You will all know that it was all symptom-based, and diagnosis itself was based on urine, glucose, and management was not goal-oriented or complication preventing. It was all symptomatic treatment, which we tell even today for our octo and nanogenarian patients. We can go to that therapy. We need not be target-driven for 80+%. Anyway, just to tell you that in that time, we don't know what complications occurred. But after 96 or 97, when these papers started getting published, historically the UKPDS for type 2 diabetes, we know that if you manage diabetes well, you will prevent these complications. And mind you, UKPDS was done with metformin and sulfonylurea and insulin. None of these modern therapies were there then. So with that itself, they showed these kind of beautiful graphs depicting tremendous improvement in all the micro and macrovascular complications. Very often repeated in diabetic forums is the percentage of even mortality getting improved with reasonable control. You see here, UKPDS intensive glycemic control, microvascular complications, but see the top, the second one, diabetes-related death. That is also reasonably improving. And micro complications are statistically significant. You can imagine 21%, 33%. All these are numbers for that study in that few hundreds of patients. However, we know at the population level, if you extrapolate, this will be a huge benefit to the burden of complications of diabetes. Otherwise, managing end-stage renal disease or other things and blindness is next to impossible in a big country like India. So, does intensive control improve confidence? The answer, I don't know, in 2026, what is the word? There can be only one answer. It has benefits. And how early, how intensive, that can be discussed. How intensive and with what? So it is not only the outcome, not only in principle the seriousness and intensive approach, how we are going to do also matters today. That's what we will come to, and that can be discussed in various facets. And here you can see here, it's interesting, this slide I have not seen repeated. This is cataract extraction also comes down. That I don't know under what complication we will include that, but anyway, that's also part of improvement in diabetes care. And UKPDS, you see the number 35. That means so many papers have come out of it. And one of the important papers here is on reduction in A1C and how MI and other. In this, they used to actually dissect out the metformin arm and say that metformin, had there been one more patient in that trial which showed benefit, it would have had a p-value which was significant, I remember. So this is 1% reduction in A1C showing reduction in MI, stroke, or what we call as MACE. This is the typical 3-point MACE which is shown in UKPDS. So what have we learned till now? Maybe this part I'll come to. This is 2008 data. So before 2008, we know that diabetes, if you control well, you can reduce complications. But what was missing in that is the complications were heavily focused only on microvascular complications, because that is what is defining diabetes. Before 2005 or 6, we didn't have much papers to say that by controlling glucose, you can prevent CV events. Then only that, and how early and how intensifies was another point. So, will intensive therapy actually lead to better cardiovascular outcomes and better other outcomes from the mortality point of view was done by 2-3 major studies between 2001 to 2006. You all know this Accord study, Advanced study, and VADT study. Those things are summarized here. From there, we learnt this important graph. And that is, in UKPDS, most of the patients were type 2, they may be 35, 45 years plus. Their duration of diabetes was more than 5 to 10 years. And there would have been somebody who with 15 years diabetes also, 12 years, whatever, more than a decade of diabetes. This was the first time when they showed that if in UKPDS, in this graph you see here, the conventional people who were on the control arm of the UKPDS, they knew the benefits of the study after UKPDS is published. They became slightly stricter in their control over the next 10 years. The people who were in the intensive arm of the UKPDS, mind you again, it is metformin and sulfonylurea only. They actually became too tight because they were controlled and they were monitored by the study team. They became slightly relaxed. In what happens after 10 years, this few years of very good control actually was carried on. The benefits of early good control is carried on even though you relax your control later. What is called? Number karma theory mari. You do good things, the good deeds, the effects are carried on later. This is called legacy effect described by Holman and team. That was a classic NEJM paper. A similar study in type 1 diabetes called EDIC study also showed the same thing. In EDIC study, even more important to remember, they are type 1, younger people, very good control, relaxation of control even after 10 years, cardiovascular events reduced. That is even more important. Type 1 we always correlate with micro complications. Here it was cardiovascular. So both the studies giving us similar information that early and aggressive therapy, good control of diabetes, even though you may not control it very well in the long term, that good effect is carried on and that favorable glycemic legacy is carried on to the next person. This is called legacy effect. The reverse is also true. If you do not control diabetes in the initial part very well, the unfavorable glycemic burden will also get carried on. That is what is shown by these kind of other graphs. This glycemic legacy also will be there. Nee tappu panna tappukku appuram dandana varungra mari. Dandana is too harsh to say that. But added on to this, you see other unfavorable lifestyle, smoking, alcohol, etc. If you add all this, it will be a very complex situation in a given patient. So we understood that glycemic management, if early and good and strictly controlled, is good. But diabetes is not that easy to control. We know if they had there will be hypoglycemia, they'll have other issues. Then came these kind of papers. The second one is the most important paper, personally I feel, even though other studies may harp on this. That is the Steno study. In the Steno study, by a nicely conducted holistic management of the components of metabolic syndrome, which is dysglycemia, obesity, hypertension, and the dyslipidemia, together, the outcome is better. And this alone, for next 1 minute, we will just harp on it, dwell on it for a few more minutes to say that if you control, we are supposed to do this only in our practice daily. Don't look at glucose alone, look at today we have to include weight, but in that study it was blood pressure, lipids and albuminuria and inflammatory markers like usage of aspirin, etc. You do this simple few things to a patient, their outcome is better than just saying that glucose is good and not giving the other drugs. So, nicely demonstrated by Steno study is that the comprehensive diabetes care addressing the components of metabolic syndrome in a nice way, their outcome is better rather than only being glucose centric or whatever that centric. Then comes this question of these slides. I'll skip to these slides, may not project well. What is the forerunner of all this? Let us not forget that the previous study, all these are because of weight gain and excess fat. If there was one pill, இந்த படத்தில் விவேக்கோட அந்த ஜோக் மாதிரி தான், ஒரே ஒரு மருந்து எல்லாம் சரியாக போகணும் அந்த மாதிரி. If you have something, it would be really nice. No, why waste our time on each individual? You give one drug which will have a good effect. 1 minute more, 1 minute. So that is what we are trying to address. That if you address obesity, and if that obesity is the forerunner of diabetes, if that concept is correct, நோய் நாடி நோய் முதல் நாடி, நோய் முதல் ஒபிசிட்டின்னு வச்சுட்டு then we are only நோயோட எஃபெக்டே பார்த்துட்டு இருந்தா, நோயோட முதல் ஒபிசிட்டின்னு தெரியுது. ஆனால் ஒபிசிட்டியை கண்ட்ரோலே பண்ண முடியாமல் we were struggling for the last 2-3 decades. So then we came with recently in the last decade we all know excellent drugs have come with safety margin. That's where I don't know whether this graph is here. The one important thing you should know is 5-6 drugs have got banned in the last 2 decades, which were claimed to be anti-obesity agents. For the first time in the last decade, we have 2 important drugs about which one drug company is talking here, on behalf of which we are talking. Excellent data is coming up that they are reasonably very safe in our obese patients, both with obese, with diabetes, without diabetes, all permutation combinations they will be showing, to tell us that these agents have to be used early on. In fact, to the extent that even before diabetes. Pre-diabetes அப்படி கூட சொல்லலாம் இல்லை, இதெல்லாம் இப்போ ஒபிசிட்டிக்கே கொடுக்கலாம். வித்தவுட் டயபிட்டிஸ்னா இப்போ ப்ரீ டயபிட்டிஸ் தான். ஒபிசிட்டிலேயே கொடுத்தாலே யூ கேன் ப்ரிவென்ட் டயபிட்டிஸ் மாதிரி ஆகிடும் in the near future is what we all believe. And personally, even though I am talking slightly emphatically, drug is also a very important arm of therapy in the holistic management of a person. However, drug alone should not be the thing, also should be kept in, because we have only 7 or 8 years data of all these agents. Long run, how much and all will be discussed further. So last 2 slides to tell us the summary of whatever I tried to convey is, we know diabetes burden is increasing, burden and all is okay, beta cell dysfunction, all the ominous octet. If you have some drugs which can address all the octet different arms, it is good. And when you address diabetes very strictly, early and intensively, you are going to have very good outcome. Why not address even more early is what is the question here. And there I think the GLP-1 based therapies, GLP and GIP together is what we will discuss in the next, I think next talk is on that. So which is going to be very, very exciting. As I think Lakshmi also said in the previous talk, we are in the face of our diabetes today, where we have so many options available. 10 years back we wouldn't have said all this. We would have said, insulin kudu, lifestyle only போறாதுங்கிறதை இப்போ கொஞ்சம் புரிஞ்சுக்கிறோம் எல்லாரும். And I am seeing a lot of our colleagues who were relatively higher BMI, many of them have lost weight healthily, and they are today I think 2-3 people I congratulated in the morning. Not that they were taking any of the drugs, okay. Thank you very much, and I leave it here for further discussion.